Helen and Mary, I just wondered what your thoughts were from both the veterinary and medical sides, from a perspective of how do we increase that engagement? What do we need to do?
I think it's got to go down the clinical and research side, particularly because humans, that's where we try to hang everything. And I see very much One Medicine as an opportunity for collaboration to inform both. On the research side, I'm fed up to the back teeth of inbred rat mouse models for pain. It's absolute nonsense. You read all these papers where you take some poor little inbred mouse, do horrible things to it, and then touch it with things like von Freyhairs and claim you're measuring pain, because pain's one of my main areas. I mean, it's absolute nonsense. And what these inbred mouse models are so different from their wild type, which is so different from the one you find running around on a road anyway. And we are using those so-called models to inform how we are developing clinical and research stuff for that. And a classic example is I look after one of the patients that survived the Northwick Park trial fiasco. And that was it was going to be a fancy supermab for inflammatory arthritis, which did wonderful jobs in rats and mice. And this was the old days before they changed clinical trial rules, and you could take a drug that had never been used in humans and put it in 4 or 5 people at the same time. And of course, they nearly lost most of them. And this poor guy I look after is a hangover from that trial. And that just reinforces again the craziness of these inbred models we're using, where you don't actually need an inbred model. Most, as you say, human medics have no idea. The same drugs, there is nothing I've seen in human medicine that doesn't exist in animals. But one of the frustrating ththings is that quite often the language is different. So I knew about progressive retinal atrophy in collies for years, because I grew up with working dogs on the farm. It took me, I think I was probably a young registrar before I discovered that's what we call progressive retinal atrophy. It's like, it's just the same thing, but we're calling it something different. We're calling it retinitis pigmentosa. You're calling it PRA. This is crazy. It is the same thing. And it's the same for a lot of the rheumatology, which is another hat I'm working in, where again, most of the rheumatology stuff we're doing not very good animal models, where you take a rat or a mouse and you inject some horrible carrageenan or equivalent into it, make it blow up a joint, kill it a few days later having done something to it, and that's supposed to be rheumatoid arthritis or an inflammatory arthritis. And yet rheumatoid is out there in dogs and in cats. It's rare, I know, but there is nothing I have seen in rheumatology that does not exist in animals as well. And those models are out there, the real thing, which we could use so much better in research and would so much better inform what we're doing. But as you say...
Could I ask a question on that subject,
Sure.
if you don't mind?
Not at all.
So the biggest single question I get asked is, if we were to do sorry to interrupt, but it's just really important on that one point. There are indeed loads of rheumatoid arthritis, loads of inflammatory arthritis, loads of infectious arthritis, loads of degenerative arthritis in dogs, cats. If you were to construct an ethically well-based, legally well-founded study on companion animals that clients at my practice would be happy to enroll in, because they ask me about it all the time, how would you go about changing the veterinary regulatory body and the human medical regulatory body to allow that study to take place?
Well, one of the things I think we need to do is start doing more combined clinics, and that's something I'm trying to establish at the moment. I want to develop veterinary rheumatology as a speciality, because veterinary rheumatology as such doesn't really exist yet. And I've been talking and lecturing more about this, and I'm seeing, while some areas, vets and humans, we're pretty similar in our knowledge, other areas there are big gaps. So the seronegative spondyloarthropathies are a huge gap in veterinary medicine. And that's an area, and we treat them extremely effectively now with all our fancy biologics. There are all these areas. So I would love to, and I'm trying to work on setting up a combined veterinary human clinic. And I think if you could start breaking down those barriers, I have to try and figure out how we're going to do that. But I can have, as a human expert, I can sit in, the vet's running it, but I'm informing it. And if you start getting that as a model that works, then people would start seeing this isn't different.
Well, that is real life One Medicine, and we use anti-inflammatory stem cells plus platelets plus a viscoelastic lubricant every day that you, in your clinic, can't even have.
I can't
right
inject
now.
hyaluronic acid into tendons, which you guys do, because we
But
don't
you can't
do
have
it
the stem
in
cells
humans.
that I have now. I know we're digressing a little bit from the definition of One Medicine, but this is the critical point. Unless you can get a proof of principle study together, and arthritis is a low-hanging
classic
fruit,
one,
as
yeah.
it was, because everyone has it, and we need to treat it. I have stuff you don't have.
Yeah.
You have stuff I don't have. We're not talking to each other, but we don't have a regulatory framework. Do you want to talk a bit about that regulatory framework? One Medicine.
One Medicine. Well, there's been a few things I've said which I've sort of picked up and been writing notes here. I think the first thing that came to mind when you asked about One Medicine was, why is the word medicine, why does that refer to people? My daughter is studying medicine to become a doctor, but I studied veterinary medicine. Surely it's all medicine. It's all medicine, whether it's in a dog, a cat, a budgie, a person, it's all medicine. So I suppose that's the first thing. So, when the people go to university, they've already split. You've already put up that barrier, which is historical, but surely it's time to change it and say it's all medicine. And certainly my experience as a vet, most of my textbooks were human. It was human physiology books that we were studying, human histology books. And then going through and doing the PhD and everything, it was always human research papers that I was going and reading. I do wonder, I don't know the answer to this, but how many of my human medical colleagues, if they were doing a PhD, would they even look at the veterinary literature?
No, they don't, I can tell you, because the other challenge for me is complex regional pain syndrome in humans. That's my other major speciality. In human dogma, it does not exist. It obviously does. I have spoken to so many vet therapists and vets, and I just need to find an interested bunch of vets and publish this, because I've already changed the human criteria so it could be adapted and used for veterinary medicine. And that's a classic example.
I sadly nearly failed my intensive care exams because I foolishly bought a book by Smith, which was Comparative Physiology, which has a dolphin on the front. And I had my human ICU book there, which said things like try high frequency oscillation for people with ARDS. And then in Comparative Physiology, it had a dog panting at the same frequency as our human. And I was just reading that book and forgot about the other one. The governance thing, I'll just throw this in and shut up. So a lot of my work in ICU was running big clinical trials in people who lack capacity. And the problem in ICU is previously it wasn't possible to do that. Classically, the cardiac arrest patient study groups, so we run the world's biggest cardiac arrest study, which is about cooling or not after cardiac arrest. And we couldn't do that a decade ago because it was thought unethical. These people don't have capacity, therefore you can't do it. And what we know is those people who lack capacity are the very patient groups that need evidence more than anything, because all the evidence for them is terrible. So now there has been a governance change, and 90% of the patients in intensive care enrolled in clinical trials do so with what we call emergency deferred consent. In other words, they do not consent. We do not even ask for consent from relatives because there's no such thing. There's assent, not consent. So I wonder whether some of the frameworks for adults that lack capacity could perhaps help in the patients that Noel's talking about in terms of the non-human patients. And that was better for everybody. It was better for us as researchers worrying about the governance. It was better for the patients because they had the protection of governance. And it was better for funding bodies too. So that may be a framework to look at.
It is about getting the regulatory bodies on board though, and the Royal College of Veterinary Surgeons as well, to understand when you've got disease that's spontaneous, it's occurring naturally, how can we use that from a perspective of an experimental study that's been designed to use patients specifically. And that happens across the board, whether it's human or animals, but we need that regulatory framework so that it can be set up easily. And I think that's so important. At the moment, that's not there.
Well, the Northwick Park trial, TGN 1412,
Absolutely.
It was predictable that was going to happen. If you looked at the literature about the black sex mouse and others with T memory cells, it was predictable. Yeah. So, but we didn't look at that literature before doing the human studies. Yeah.
Did you want to come in?
Yeah, of course. I mean, I'm in massive learning mode today because I was first introduced to Human Animal Trust and the One Medicine message just a few weeks ago. But I think there's real opportunity, and naturally I'm going to be prejudiced toward infection because that's where I spent 18 years of my professional career working to improve outcomes from sepsis, which is the way an organism's body responds to an infection. And we've talked about rheumatology. We haven't talked about cancer. We are both in the human and animal world moving very closely toward precision medicine in each of those areas. Sepsis and infection, we are light years away from it. And I think that's where a real opportunity in my world comes here. We talked earlier about immunomodulatory therapies in people with sepsis. We've had interleukin-6, we've had antithrombin-3, we've had activated protein C. They've all failed prospective validation studies because the cohort is just too vast. And just as in humans, we don't know which animal with an otherwise fairly benign infection is going to develop sepsis and threatened or actual organ failure. We don't know which human is going to do so because we don't understand the biology with any degree of precision. And I think there's real opportunity here for collaboration to begin to understand that biology, to begin to understand the phenotype of any animal that is progressing toward a sepsis type response, so that not only can we treat that individual animal, but also we can apply antimicrobials much more judiciously. And then the only other point I had relates to a much earlier step in the conversation, which is I didn't grow up on a farm. I grew up in a council estate, and I had to work really bloody hard to get to where I am now. And I'm driven, I think, by a very ingrained sense of injustice and inequality. And a point I'd like to make, which is perhaps more to the One Health and the One Medicine agenda, is just as with non-human animals, if you concentrate humans, you take them out of their natural habitat, you concentrate them in unnatural population densities, you feed them poorly, you nourish them poorly, you don't provide access to basic preventative healthcare, you displace them, whether it's through war, through famine, through poverty, through climate change, any of these aspects, they will develop more infections more frequently, they'll have poor outcomes from those infections and sepsis as a consequence of them more frequently. And I think, again, we have to learn lessons from both environments, whether it's the human world or the animal world, to work out how we can provide that welfare more equitably.
And if I could say on that subject, and on the subject of comparison, whether it's a council estate, this room, a palace, or a dog's environment, Pseudomonas aeruginosa, MRSA, E. coli, all identical microorganisms. It's not like they're different microbes, they're identical. But
They're
we're
a bit
not
different.
genetically, from a genome perspective, because of the phenotype that they're in, as well as their genome. He's the expert on this. But what's the point I was getting to before you jumped in, which was wonderful because I was waiting for that, was your point on medicine being the same. We call them the same bug, right? The public would easily relate to the fact that MRSA in a dog is the same as in a human. They're a bit different, as you said. But understanding his question, which is how the phenotype of my Airedale Terrier and his patient and the genotype of that microbe, which he desperately tried to teach me for my board exams.
Kind of worked.
Didn't, for which I'm deeply grateful. Slightly different, but more the same than different. But my point was they're called the same.
Yeah, that's right.
And that's really interesting. Yeah. Sorry, Rob.
No, not at all.
The reality is that a multi-drug resistant dominant species of E. coli is an ever-accelerating threat, and that's going to have catastrophic consequences in all animals.
So you would agree that as the resistance of the bug accelerates, that's applicable to both animals and humans?
Of course, absolutely, yeah. But it depends what drugs are using in those animals, because you might be able to treat it in one and not the other, depending which you've got at your disposal. Danny, anything you want to add to the conversation before we move on?
Yeah, there's two things. One, you'd mentioned the studies you do without consent in emergency situations, and I guess the reason that is ethically acceptable is because when you don't know what the best intervention is, you're not withholding someone. It's not an experimental treatment, is it? If you're still trying to work out which is the best way to treat someone. But to touch on your point and what Noel said before about this being a fair deal, I think that is how you have to sort of sell this concept to people who have either the power politically to change legislation, or people who have the finances, like people who say that drug companies and that kind of thing, is to make sure they understand that it is more cost effective and more efficient to work in this way than it is to work separately. This approach you have, like you're saying, Noel, you've got drug companies where drugs pass they pass animal trials, they get licensed for humans, then they're not licensed for animals. Then there must be a way of structuring the regulatory and political and business system so that it is more cost effective for those drug companies to then release these out for animal use.
I couldn't agree more. A colleague of mine, Dr. Matthew Allen, Prof. Allen, is doing a clinical trial right now on immunotherapy and osteoarthritis, and he insisted at the beginning of the trial with the drug company that it was made available for animals at the end, because they are taking animal lives in this study, but he insisted that the outcome is fair to animals. So it is possible, but it requires the will, and the biggest single challenge is short-termism, because politicians and everybody else can't see beyond 4 years because they don't have the longer-term goal, they have the short-term goal. And the same is true of clinical studies. The drug company wants the result within 2 years maximum. Who's going to spend say $1 billion on developing a cancer therapy and not have the result within 2 years that they want to sell the drug? Nobody. So what we have to do is convince them that they can save $500 million if they do a contemporaneous study in dogs with prostate and bone cancer and save money. And but getting your example is brilliant. The police, the mental health, brilliant example, because the knock on the prison service, and I've been in prisons and I know that myself, not for the reason, not for the reason of not knowing that the bacteria were different. But my point is that your analogy is perfect, and it's because of an inability to link together, and that's where we come in. But then it's lobbying for legislative change and to encourage the drug companies and the implant companies to understand they save money and ultimately win more if they do it this way. You're right, 100%.
And one of you will probably better answer this question better than me, and I should know, I'm on the Council of Royal College of Veterinary Surgeons, but is it the professional regulatory bodies that are preventing this? Because I assume that it's going to be more, legislation, animal welfare legislation regarding things like animal testing and drug research. Then I don't think the RCVS are stopping vets doing experiments, because there's other legislation that covers that area.
So I've been through this several times,
have you? Yeah.
And no point in picking out one individual. Systemically, it requires influence at RCVS level, and the same will be true in the human medical level, General Medical Council level, at the VMD level, and at the MHRC, is that what it's called, level? MHRA, the other one's the tax people, yes. That's why that's ingrained in my mind. Yes, oh yes, that's why that's ingrained in my mind. But at all levels, it requires, the power of this room, in the 10 years I've been trying really hard, I've never seen the power of this kind of synergy. This is way more powerful, because it's unlikely we're all completely ludicrous. Unlikely, statistically improbable.
No, absolutely.
But I think it's almost more basic and societal than this. It's around placing value, the value that society places on preventative healthcare, on health and well-being, on function. And at the moment, certainly in the human world, we are very focused on interventional healthcare rather than preventative healthcare. And until we change the value society places on it, we're not paving the way for the politicians, for the government or for our professional societies to smooth this journey for us.
We don't deal with obesity, for example, we're going to end up with diabetes problems.
You can't fix obesity in 4 years.
Can I just come in there? I spoke to a nurse a few months ago who works for the Diabetes Prevention Service. She told me they prevent 18,000 people a year from developing diabetes, and she said they're having the funding cut as a cost-saving exercise. Quite clearly, that's not going to save anyone anymore.
Sorry, Mary, that's because in the human world, the people who are paying for this is the Department of Health and Social Care. The people who are benefiting from it is the Department of Work and Pensions, because people are productive in society if we save their lives. We need to connect all of this together so that we understand, again, the value of preventative healthcare and health and well-being.